In this session, we are going to continue to discuss the translational science component of translational research, the transition between translational research and translational science. And I'm really delighted that we have two wonderful young investigators who are from our KL2 program, who have agreed to present some of their ongoing work here, and that we'll use this as a springboard to discuss issues around, as we talked earlier, about how you take a translational research project and start thinking about the questions that arise in terms of translational science. And it is important to as we reflect on this, and you'll hear from Max and Lauren in a moment, that the quality of the translational research has to be good to start with. It's not like, we will never really advance the field if we say we'll take crappy translational research and we'll turn it into science. So you've got to do good, and you will hear two incredibly talented young investigators talk about their translational research, and then we'll explore what the issues might be. And I really want to encourage you to think about this and to ask questions and to help us walk through this, because I think this is valuable not only obviously for the two young investigators we have here, but also for our own general investigative community and thinking how we might advance the field in that way. So the first presentation will be given by Max Petersen. Max is an assistant professor of medicine in endocrinology and metabolism and lipid research, and has been working for his KL2 on impacts of diet and the weight loss. Over to you, Max.
Okay, thanks for that introduction. My name is Max Petersen. I'm incredibly grateful to the ICTS and the KL2 program. This is completing my second year in the KL2 program now, and it's really given me the opportunity to sort of explore what I would like to do as a clinician scientist in the future, coming out of my endocrinology fellowship. I've had the opportunity to work over the last 5 years on this project about does dietary composition impact the metabolic benefits of weight loss? And I would consider this really a basic science project, and I'll sort of explain why, even though it's conducted in people. And you alluded to some of the challenges in translating basic translational research into translational science, and I said that I've been working on this project for 5 years, but one of my mentors, in addition to Sam Klein, is Gordon Smith, associate professor, who's been working on this project for about 10 years. So just to give a sense of the scope of how long it takes to generate this basic knowledge about what would seem to be a fairly simple and straightforward question: does diet composition impact the metabolic benefits of weight loss? So how can we know what diet is best for obesity treatment? Nutrition science is an incredibly messy field, and I think part of the reason I like to use the analogy of the blindfolded people touching different parts of the elephant and coming to different conclusions about what it is they're touching, to sort of understand the challenges in nutrition science, because we have different ways to ask the question, what diet is best, and they yield different answers. So for example, nutritional epidemiology, which has this really big challenge of dealing with sort of unreliable input data to try to discern very small effect sizes, has many limitations and is profoundly, is hypothesis generating in nature, and comes to certain conclusions about reducing sugar-sweetened beverages and promoting plant-based foods, reducing the consumption of red meat. And these are, this is largely the sort of input data that goes into our national dietary guidelines. At the top, you have randomized trials of dietary guidance. We've had many randomized trials of dietary advice, many published in, our most prestigious journals in the field. But fundamentally, these are not randomized trials of diets, they're randomized trials of dietary advice, which is something subtly but importantly different, because the average participant in these trials does not take that advice to a degree that allows you to actually assess the physiology of the diet. If you want to truly understand the physiological efficacy of a diet, you have to conduct a controlled feeding study where you actually control the food. But this is expensive and challenging and labor-intensive. It limits the sample size, it takes a long time, and it costs a lot of money. And most controlled feeding studies are done in the span of 2 to 4 weeks, which is arguably too short to observe significant adaptations that might occur in a response to different diets. And then implementation research addresses a completely different question about how feasible a certain dietary approach might be in the real world. I would argue that before we enter into the world of implementation research and translational science, we need to have a better understanding of, under ideal controlled conditions, whether different diets lead to different physiological effects during weight loss. We conducted a controlled feeding study in the outpatient setting to address this question. It's called Weight Loss with a Ketogenic Mediterranean or Plant-Based Low-Fat Diet for Metabolically Unhealthy Obesity. We studied adults aged 18 to 55 with obesity, prediabetes, and hepatic steatosis, which is now the term is metabolic dysfunction-associated steatotic liver disease, or MASLD. This disease has undergone various name changes over the years, as you may know. We excluded people with type 2 diabetes who had significant other diseases, who had undergone weight loss surgery or were currently taking obesity medications. And after a rigorous baseline testing to understand the insulin sensitivity, liver health, and other metabolic characteristics of these participants, we randomized them to either a ketogenic diet, Mediterranean diet, or plant-based low-fat diet to achieve supervised weight loss of about 10%, which is about the degree of average weight loss seen with Ozempic, for context. All food was provided to the participants as packed-out meals prepared by the WashU Metabolic Kitchen, and you can see examples of these foods on the right side of the screen. And so participants logged their foods, they met with a dietitian weekly, but importantly, over the full several months that it took them to achieve 10% weight loss, they were eating the food provided and not responsible for preparing their own menus. And these 3 diets, I'm not showing the composition here, but they span essentially the entire spectrum of macronutrient composition possible for the omnivorous human diet. A ketogenic diet is extremely low in carbohydrates and very high in fat. A plant-based low-fat diet is the exact opposite, very high in complex carbohydrates. About 70% of calories are coming from carbohydrate, and only about 16% coming from fat. And a Mediterranean diet is a balanced diet, low in saturated fat, sort of compliant with what is recommended by many society guidelines. After we achieved matched 10% weight loss in all 3 of these groups, we stabilized the weight-reduced state for 1 month so that we weren't studying people in negative energy balance, and repeated all metabolic testing. I'm not showing the full participant characteristics for the sake of time, but we had 14 individuals in each of the groups. So a total of 42 individuals being studied, and I already told you the duration of the study, giving you a sense of how intensive the intervention had to be to really control all these variables and conduct rigorous tests of metabolic health. So really there are 2 possibilities being tested. There's what I call the diet nihilism model, which I think many clinicians have come to over the years. That is, the only thing that matters is the amount of weight loss, regardless of how you achieve that weight loss, what diet you use. The thing that really matters for the benefits of weight loss is the amount of weight loss. And then there's the path dependence model that says that maybe you get a different result with respect to insulin sensitivity, liver fat, if you lose the weight using a high-fat, low-carb diet versus a low-carb, high-fat diet versus something in the middle. So which of these is true? Here are the results for insulin sensitivity. All 3 diets produce similar improvements in whole body and skeletal muscle insulin sensitivity. This is measured using the gold standard assessment of insulin sensitivity, which is called the hyperinsulinemic euglycemic clamp. This is conducted in the clinical translational research unit here. And whole body insulin sensitivity, shown on the left, increased after weight loss with all 3 diet groups, with no weight loss by diet interaction. Same result for skeletal muscle insulin sensitivity, which increased by about 50% after weight loss in all 3 diet groups. However, we saw a slightly different result with respect to liver health. Liver fat content decreased on all the diets, but the improvement in hepatic steatosis after weight loss, shown in the third graph, was greatest in the ketogenic diet group, about 65 to 70% on average, compared to about 45 to 50% reduction in the other two diets. Liver insulin sensitivity also improved the most on the ketogenic diet, and rates of de novo lipogenesis, which is the process of the liver creating new fatty acids from carbohydrate precursors, was shut down on the ketogenic diet, was decreased moderately on the Mediterranean diet, and did not change at all on the plant-based diet. So there is path dependence with respect to the effects of weight loss on liver health for diet macronutrient composition. However, in adults with obesity, prediabetes, and MASLD, 10% weight loss improved whole body and muscle insulin sensitivity independently of the diet used. But several MASLD-related outcomes did improve most in the ketogenic diet group, and no outcome that we've measured, including many that I'm not showing here, had a weight loss by diet interaction favoring the Mediterranean diet only or the plant-based low-fat diet only. Thanks.
So we'll entertain questions from Max after Lauren's presentation, and I'm delighted to introduce Roland, who is a rare phenotype in herself. She's a woman surgeon. She's in the Department of Otolaryngology and head and neck surgery, and Lauren is also a KL2 scholar with us, and we'll talk about her work on invasive fungal sinusitis.
Great, thank you. So I'm very lucky to be in the KL2 program. I was also an MSCI graduate, and then when I was here as a resident, I left for a couple years, and now I am back, and I'm a rhinologist, so that means I do sinus surgery, and my interest area is invasive fungal sinusitis, which is just like it sounds. It's when the fungus that we all are exposed to and breathe in, it takes a turn and is invasive, and it can invade through blood vessels, mucosa, bone, and ultimately it gets to the brain or to the orbit. It primarily affects patients that are really immunosuppressed, and that's a problem because the numbers of bone marrow transplants in this country are increasing, and so we're having more patients who are vulnerable to the disease. Morbidity is high, and that's because the two treatment options that we primarily depend on have a lot of morbidity. So we have very toxic antifungal medications that are systemic medications, and then we have very morbid surgery that's aggressive, and this is being done in patients who are very sick to begin with, who have low platelets. We're removing their orbit potentially, so it's very terrible surgery. And despite all this, mortality is still high. It's about 50 to 80% at 6 months. So it's a terrible disease, but it's rare. And I've worked and trained also at Emory and UCSF, so big institutions like WashU, and we have about 15 cases per year. So it's good that it's rare, but it makes it hard to study. And so the translational science topic that I was going to mention is addressing a roadblock that I have with my research, and that's in studying a rare disease. And there's two ways that I've tried to overcome that. And one is using national databases. And the second is expanding my biobank that I have. So I collect tissue and blood from patients undergoing surgery. And I'm trying to expand that to multiple institutions. So first, for national databases, the first problem I had is that there's no specific ICD-9 or ICD-10 code for invasive fungal sinusitis. So it's not possible to confidently use a national database. A couple previous studies have used combinations of codes, but they never validated if those were truly the right patients. And you can't look into the charts of those patients because it's de-identified data. And so we used Slicer Dicer, which is a tool in Epic, and we made different algorithms of codes and then compared it to our gold standard, which is a pathology database where we know the patients have the disease. And so I had multiple algorithms of codes that included immunocompromised codes, sinusitis codes, fungal codes, CPT codes for evidence of a sinus surgery while an inpatient, and then these drug codes, which these patients are on these very toxic antifungals that most patients are not going to be on. And so we looked at the sensitivity and specificity of all the algorithms, and algorithm B had very high sensitivity, but you can see that one of our algorithms, algorithm E, had the best positive predictive value of 92%. And so we wanted to then go and use that in databases. So first, we repeated our study at 2 institutions where I had friends who also had Slicer Dicer and also had a pathology database, and they confirmed that the positive predictive value was also in the 90s. And so we've moved forward looking at national databases using this algorithm to more confidently identify patients. And then one of the residents at Houston Methodist has also used a different database, and now so we're submitting both of these papers. And so it's moved us forward a little bit. The other thing I'll mention is my biobank studies, where every patient who consents, when we do surgery, we take some of the extra mucosa that we take out of the nose and we study it in the lab. We can also collect blood from patients if they consent, so it's sort of extra blood that we take while they're asleep, and we also keep that in the lab or freeze it for later use. And so through these studies, we've looked at bulk RNA sequencing and Western immunoblotting and looked at some different things in the actual tissue. And one thing we've become interested in is MMPs and TIMPs. And these are proteases that have inhibitors. The TIMP is the tissue inhibitor of the protease. And we've become interested in these sort of ratios of these proteases to their inhibitors. And we found that in our disease state, that ratio is off. So there's too much degradation of tissue, too much protease, and not enough inhibitor. And then we've taken this to the next step of doing some staining here. So you'll see on the bottom row, that's my disease patients, 3 different patients. The top row is control patients. And the MMP is the protease. So there's more protease that we see in the diseased patients, less in the control. And associated with that extra protease is decreased claudin-1, so that's in red. And claudin-1 is an epithelial protein, so a gap junction protein that should be there to keep the epithelial cells together. And when it's not there, that can allow things to spread. And so we started thinking it might be that the proteases are degrading the tissue and allowing the continuation of fungal spread. Through our blood collection, we have looked at CyTOF in our PBMCs, and we found that CD4 T cells appear to be particularly important in these immunocompromised patients in terms of invasive fungal sinusitis survival. And then we've used Codex to look at CD4 T cells that actually make it into the tissue, and again have found that that is probably important. So not really the targets that we normally think about in invasive fungal sinusitis, where we're previously really more focused on the innate immune cells. And so we have these new potential targets for therapeutics. Should we be thinking about T cells? Should we be thinking about blocking MMPs, having an MMP inhibitor? The nose is great in the sense that we can use topical therapies. We don't have systemic side effects if you can spray something in the nose. And so we started thinking about these new therapeutic options for this disease that really doesn't have great therapeutic options. But first, we need to validate our findings, and we have a low N at a single institution. So we started thinking, are there commonalities with other diseases that we can be looking at so that we can study these concepts in a larger number of patients? And that's another translational science sort of factor, is can you look at other disease states to sort of help you move your science forward? So there's 2 things I'm doing now. One is I'm expanding through the development of a national IFS consortium. And so instead of just me collecting tissue and blood, I have other institutions who are interested in participating. So I have 5 universities that have active IRBs to collect their own tissue and have their own biobank, doing it sort of the same way that we do it. 2 of those have submitted transfer material agreements, and 1 has been accepted. And this is a long process, and it is a little bit painful, just because we do need some patient information, and we also need the actual tissue and blood. So it's a little bit complicated. And then the second thing is I've thought about other diseases that have commonalities that we can look at. And so in December of 2023, I helped organize an NIH workshop on allergic fungal sinusitis. And allergic fungal sinusitis is a different form of fungal sinusitis that's not invasive. So it's more common, it's associated with polyps, and it's less deadly than invasive fungal sinusitis. And so since it's more common, there's more people studying it. We had a workshop, Jay Piccirillo was there, rhinologists were there from around the country, immunologists, pulmonologists, infectious disease specialists. And the goal was really to network with like-minded scientists who are studying similar things. And interestingly, one of the pulmonologists was studying claudins. So before I mentioned anything, he gave a talk on claudins and how he's studying the interaction of fungus. And there's a bunch of claudins, not just claudin 1, but he's studying different claudins in the lung to see how fungus interacts with the epithelium to change claudin expression. And also, MMP inhibitors are utilized in other disease states to stop protease degradation of other types of tissue. And so I do think that we can look at other diseases to learn more about invasive fungal sinusitis. So those are the things I'm trying to do. Thank you. And I have used many cores of the ICTS, so thank you for that. The tissue procurement core keeps all of my specimens, does a lot of processing, but also stores them. IML has been a really helpful codex. We're just starting that, and it's really cool, as well as SciTOF, and then GTAC for sequencing help.
Thank you both for really superb presentations. So as Dr. Hara mentioned in response to one of the questions that came in after her session, is that we're not at a phase, we believe, that young investigators can write a grant for translational science. But what we think is where we are is that you can include a translational science aim as one of the aims in your overall research. So what I'm going to ask you now is where do you want to, if you're thinking about your R01, your next major grant application, what are you thinking about? And let's talk about your translational research component first. So what do you want to focus on as you emerge from the Career Development Award into your own independent research, and what would that be? And then I think we can discuss where the opportunities might be to think about a translational science aim. But let's talk about your translational research first. So Max?
Yeah, so in my case, I will say that I'm currently applying for a K23 award, not an R01, and actually moving to a slightly tangential area, which is, I would consider this, the research that I presented broadly, some of the promise of a ketogenic diet for cardiometabolic health and metabolically unhealthy obesity. There are also perils of ketogenic diets, and one of the most well understood or well known, but maybe not that well understood in my view, is development of high cholesterol and why this occurs just in some cases dramatically, particularly in lean individuals. That's the problem I'm going to work on moving forward. But maybe for the sake of this panel, it'd be worth thinking about translational research in science as it pertains to this particular problem in metabolically unhealthy obesity. I think one thing we've learned from extensive randomized trials of dietary advice is that giving people advice to restrict carbohydrates dramatically leads to short-term benefits and long-term regression to the mean. And so I think that the paradigm of just providing dietary advice to our patients has been shown over and over again to be insufficient to actually achieve population-level results. So that means that new paradigms need to be tried. I would argue that this research provides an impetus for finding new ways to implement a therapeutic carbohydrate restriction in metabolically unhealthy obesity. It says that maybe there is something here. This is not a therapeutic approach that should be given up on because it's failed in large-scale clinical trials. But maybe additional support, ways to provide medically tailored meals, as have been used in heart failure and other conditions for this, could be explored in a more structured way than the sort of generalized dietary advice and meeting with a dietitian that has failed repeatedly in randomized trials.
So, as you said, you're maybe taking your own research in a different direction. But let's talk a little bit about what you did find, and that was the intriguing notion that the phenotype of the patient may actually, in other words, whether they had liver disease, metabolically associated liver disease, was in fact a driver. Do you see the opportunity of creating some interactions with the physician groups that look after patients with liver disease? In other words, as you think about this, I mean, one of the things I think that we often get stuck in narrow foci based on this is my, I'm an endocrinologist in your case. But in fact, the bulk of the patients are not being treated by endocrinologists. They're being treated by liver specialists. So how do you engage the liver community into further exploring, understanding this sort of work? And that in and of itself, when you think about, if this is true, it's not just, you're going to have to engage with the patient population, patients with liver hepatic steatosis, but also with the community of providers who look after that patient population. So how would you think about engaging with those populations?
Yeah, it's a great point, and actually it's even broader than that because, steatotic liver disease is so common. There are parts of the U.S. where over a third of the population has hepatic steatosis, that it's actually primary care who is providing most care to people with steatotic liver disease, even if they're unaware that the patient actually has the disease. Hopefully by the time, a significant fibrosis has developed and liver function tests are starting to be grossly abnormal, hepatologists, yes, are caring for those patients. But most of the people in America who fit the category of people we studied, obesity, prediabetes, hepatic steatosis, are not under the care of any specialist at all. And so identifying them becomes a real challenge because the screening tests for identifying hepatic steatosis by imaging are not commonly done. And the sort of lab-based screening tests, such as the FIB4, which takes into account the platelets and the transaminases, is really a screening test for fibrosis, not for steatosis. And so this is it's a much broader question than just engaging with specialists at an academic medical center.
I think you've now raised really a sort of a very interesting pathway, not necessarily that you would take it, but if you think about it in terms of potential implications of your findings, and they obviously would need to be expanded. It is actually, is this treatment or prevention? Could we prevent, one of the most common cause of liver transplant now in the United States is not hepatitis C, which it used to be. It is in fact metabolic liver disease. There's a school of thought that we don't have to worry about it, we'll just give everybody Ozempic. But that's not necessarily the best preventive approach. And so could you think about how we might engage as academic communities to expand this work and make it relevant to the wider community and make it understandable to the wider community?
Yeah, there are various startups that have tried to implement therapeutic carbohydrate restriction and develop partnerships. It's a challenging space, I think, to commercialize. But the thing is that everybody eats. Not everybody wants to take medicine. Not everybody can afford GLP-1 based medicines, despite their remarkable benefits for weight loss, and increasingly, being shown as well in both steatotic liver disease and fibrotic liver disease. But not those medicines are not widely available to this extent that they're needed in the American population. But neither are food-based interventions, because the cost of these prepared meals is considerable, and there are it almost becomes a policy issue where the food that is cheaply available to most Americans is not medically tailored food or medically recommended food. It's obviously more complex than that. Yeah.
So Lauren, you outlined some of the challenges that studying a rare disease in particular, and I was very intrigued by the idea of the looking at allergic sinusitis, which has parallels, although obviously the immunocompetent patient handles the fungi in a different way. Where do you see taking this next? I mean, you've already started, I think, some of the really important issues of developing a consortium, because you can't just, study this at one institution. Do you see where do you see the greatest opportunities from a research perspective?
Yeah, so in terms of grants, I'm focusing on sort of three components of the disease. One is the fungus, another is the host, which is the epithelium, and then another is also the host, but the systemic immune system. And the immune system is the hardest. That's how I'm using blood to study that. That's probably the most complicated, because immunology is complicated, but also because the patients are so different. It's a heterogeneous population, and so it's hard. And so the ways that I'm studying, or I'm hoping to study fungus, is through sequencing of the actual species, because there's probably a difference, even though it might all be Aspergillus, there's probably a difference in the people who have non-invasive fungal sinusitis or non-invasive fungal lung infections and the people that have invasive. There's probably some kind of mutations that could be targeted through topical or inhaled for lung, and spray for the nose through therapy. There's a rise in antifungal resistance, and so there's probably things that we need to be doing differently with antifungals. In terms of the tissue, I'm focused on next steps is thinking about therapeutics that can target the MMP, so very targeted therapeutics that aren't targeting all proteases, but are just targeting those that we think are most critical, to avoid all the side effects of blocking something that's useful for other purposes. So those are my next steps, and I think that given that I've now learned what other people are doing more in this field and in the field of sinusitis, in non-invasive fungal sinusitis, but also in terms of pulmonary research and just in terms of MMP inhibition in general, I think I can apply those concepts to my work.
So I'd like to open this up for any other thoughts, observations, questions that people might have. I think one of the things that when we think about translational science, it's actually broader than just generalizability. We've talked a lot about implementation and understanding implementation and using the principles of implementation science to help us think about translational science. But really, I think I'd be interested in how you think about this. One of the ways I think about it is that if I'm a researcher at an academic institution, what can I do now that if I find something positive will increase its adoption more rapidly than we have up to this point? Because one of the things, Ruth was talking about it earlier, this valley of death. In my mind, there's actually two valleys. The first is that we have a discovery, and it takes us 10 to 15 years to develop a new drug, diagnostic, whatever. And then we have another valley, which is another 10 or 15 years before it's widely adopted by the community. So if what you're doing is relevant, and it ultimately is going to make a difference, it's to think early about how can I create, where will the barriers be for this to be more widely used? You've talked a little bit about the fact that the vast majority of patients, for example, since obesity is so prevalent in the United States, most patients are not seen by anybody with specialist knowledge, and therefore we have to have, in my mind, we have to have very simple procedures, guidelines, approaches that can be adapted widely, don't cost a lot of money, and don't require us to re-educate the entire medical profession, because it won't work. So do you want to just respond to that a little?
Yeah, I guess my response would be that in addition to not having the expertise in these sort of population science, larger translational considerations, as a clinician, I would like to know the answer to the simple question, if my patient adheres to a diet, which diet is best? And we still deliver care at an individual level and a personal level. And because randomized trials of dietary advice fail does not mean that an individual should not receive dietary advice, because some individuals actually will adhere to a diet. And if they adhere to a diet perfectly, studies like the one I presented can give you some sense of whether that composition is likely to impact the effects on metabolic health. But the important thing is to follow up with them. Check in a couple of weeks, how's it going? If they decide that this is not for them, you move on to another tool. Right? We have many tools in the armamentarium for obesity and metabolic care. Many people want to start with diet. Many people will not find that diet is the ultimate tool that leads to adequate treatment of their disease. But I come back to the value of that individual patient-doctor relationship.
Question?
Yes, hello, it's to Dr. Petersen. So a number of studies have already proven that when patients are provided with prepared meals, they do well and they decrease their weight. So the problem arises when they are left alone, to prepare their own meals. I guess you are familiar with this. So what do you propose from a community perspective, educational point of view, like how to educate these patients to prepare their own meals in a way that they could continue this treatment?
I would say that education is only one part of the problem. Some of my patients don't know how to prepare their own meals, but many more of them, cannot afford healthy food or don't have the time because they have many other commitments. And so I think at a policy level, these are policy choices ultimately. We subsidize certain kinds of food and we make certain kinds of food cheap and widely available. And until that changes, changing what people eat at a population level will not occur. But at an individual level, some people are willing to make considerable effort and achieve dietary change. And I just view this research as informing those individuals.
So I'm going to wrap up in a moment, but Max, what I would say is that question actually will give you a translational science aim, because it is, what do we do at the end of the study? And it may be, we gather the evidence to show that to sustain this, we need to have a policy change. It goes back to what Ruth was saying. It's ironic because we have a current Secretary of Health and Human Services that has not helped. But one of the things he has raised that probably is true, and that is that the diet we take is not the healthiest diet in the world. But we have to provide evidence, I think, of why that is the case, what are the alternatives, and less polemic and more data would help. Lauren, I'm just going to say, just to finish up, I mean, I think one of the things that I'm really compliment you on is developing this workshop around the allergy, because I think ultimately a very similar approach of developing a community of providers to make recommendations and guidelines based on evidence will be a way of starting this more wide adoption of the evidence that comes out of the research programs. And so starting it early by creating this community before you have all the data, but getting people to talk to each other, getting people to work together is really a very important part of this overall translational journey. So thank you both for really excellent presentations, and I've really enjoyed it.